And I would like to introduce Professor Thượng Dũng to present the topics optimal PCI in the elderly, kids or cheap. Yeah, Professor Thượng Dũng, please.
Thank you so much for your introduction. Can you see my presentation?
Yeah, we can see now.
Okay. The first, I'd like to talk about the elderly patient in the PCI. But you know, by now, the elderly patient account for majority of case come into the cath lab. According to the definition of the elderly, look like in the Vietnam, greater than 60 years old is the elderly, or is old patient. But in the cath lab, 60 years old, I think account for greater half of the patient, 70 years old, 20%, 80 years old, 12%. So, and by now, we have many PCI involved trial and registry include the elderly, greater 75 years old. So I think from the viewpoint of interventional cardiologists, the elderly patient often should greater 75 years old. And by now, according to the data, this is the data from America in the cath lab in the time 2008, 2014, it means the 6 years. After the 6 years, the nonagenarian, octogenarian doubling, as you see. And this is in the data, the nonagenarian in the data of the Dr. Go and Dr. Gupta, and in the 10 years from 2004 to 2014, the percentage of the nonagenarian increased 50%. So it's a proof for population patient, elderly population account for majority of the patient go to the cath lab. And I like to say something about, because today our program broadcast live to the meeting of geriatrics meeting in Hanoi, and there are many young doctors, many young geriatricians. So I say a little bit detail about here. As you see in the right, the picture in the right, the old man with the 100-year-old, and he set the record marathon in the 2011. And you can compare to the right, the young guy with the 50-year-old, but he suffered from Alzheimer's disease. And all the day, all the time, he is on the bedridden, no do anything, no think anything, no enjoy anything. So who is older? Who is appropriate for PCI? So we have the concept. Oh, look like it. Biological age, and 152 is the chronological age, but we must set the biological age. Why are elderly different, or what makes elderly different? Aging process have effect on the cardiovascular system, impair endothelium function, so more prevalent for risk factor, impair function of the sinus node, so very easy to arrhythmia, bradycardia, increase stiffness of myocardium on vessel wall, reduce response to the beta receptor, beta adrenergic receptor. So maybe they, when the elderly fall into the cardiogenic shock, maybe vasoactive drug work not effectively, every function decrease. And the net effect, large reduction of cardiovascular reserve reduce. And if it reduce when the patient fall into the compromised hemodynamics, it's very easy to fall into the cardiogenic shock. And what are the elderly different? This is the age-associated condition. It do explanation for the biological age. The first, the elderly have the chronic kidney comorbidity, multi-comorbidity, chronic kidney disease. It's very vulnerable to the complex agent. Chronic anemia, very vulnerable to bleeding. Chronic lung disease, very acute respiratory failure. Altered drug metabolism and distribution of drugs, hormonal regulation change, and the last look like in the presentation of Dr. Van Ng, frailty, disability, cognitive dysfunction, and aging process have effect on cardiovascular system, particularly for PCI. As you know, atherosclerosis disease affect not only in the coronary artery disease, affect all the artery, look like peripheral artery disease. So we have a poor vascular asset. And in the coronary artery, they often have the dilatation, tortuosity, medical calcification, or diffuse multi-atherosclerosis, multivessel. It made the interventional cardiologist sometimes get reluctant or not determine which lesion is the culprit lesion and which lesion is appropriate to fix. So it made the PCI in elderly require advanced techniques and more as the instrument. And we turn to the picture again. We have the picture one woman 78-year-old in the left, and one woman 85-year-old in the right. In the left, the woman is bedridden. They must intravenous nutrition or someone. And in the right, in spite of her have older, but her can take the participation in the race for the elderly. So who is appropriate for PCI? I think certainly all the interventional cardiologists choose the right woman. So in the my topic is optimal PCI in the elderly, kit or chip. So what is KISS? KISS is a chip. KISS is simple and stupid or safe. It means when we do PCI in the elderly or previous strategy, KISS keep it simple and safer. How we can do? The primary goal to improve the quality of life, no lengthen the life. So we treat only refractory symptoms, we treat culprit lesion only or culprit artery only. We treat the main vessel, we treat the large branch only. And we consider biological age, comorbidity, and risk of complication. It means we keep the procedure simple, safe, always pre-dilatation with balloon before we do stenting. Consider radiant approach for reduce the bleeding risk. And what is the chip? The chip, complex high-risk interventional procedure, complex high-risk indicating procedure, complex high-risk interventional patient. And nowadays, sometimes we call shorter complex PCI or high-risk PCI. It means we do the intervention for very complex anatomy lesions, such as the CTO, such as the left main, the triple vessel disease. In the patient, very high risk for complication. It means comorbidity, kidney, chronic kidney disease, or heart failure. So the patient very easy to fall into the compromised hemodynamics, acute heart failure, or cardiogenic shock. So according to the definition of SKY 2020, a complex PCI, it means the first anatomy multivessel calcification. We have just listened to the presentation of Dr. Kumar. And comorbidity, diabetes, cardiogenesis shock, valvular heart disease, acute coronary syndrome, heart failure, so on. And the last, the consensus of the SCA 2020 give more. To do the PCI in this complex PCI, we must need to more equipment to such as we need intravascular imaging, IVR, OCT, intercoronary physiology, FFR, IFR, guide, catheter extension, Udacilla, special coronary wire, special balloon, cover stand, atherectomy, rotablator, orbital atherectomy system, intravascular retrogypsy, laser, and polyprotection, filter wire, mechanical circulatory support, balloon pump, impeller, ECMO. And by now in Vietnam, we have IVRS, OCT, FFR, IFR, microcat, Udacilla, a special wire, special balloon, cover stand, rotablator, just only rotablator, filter wire, balloon pump, and ECMO. And so by now, many authors say, by now, the PCI in the elderly in modern area is the constant tension between kit and chip. Because in the basin, elderly basin, the lesion often very complicated, very diffuse, very calcification. We cannot do with the simple methods. And we must consider between PCI and CABG bypass surgery. This is the role of the heart team. To the right side, if prefer bypass surgery, to the left side, to the right side, prefer for intervention, we must consider guideline based on preference, resources, operator skill, complex of the lesion, the breadth of ejection fraction, diabetes, high frailty, comorbidity condition, EGFR, score, STS risk, no emergent clinical intervention. So, the interventional cardiologist, when we have the plan to revascularization for the elderly patient with the coronary artery disease, we must consider two revascularization strategy, bypass surgery and PCI, where we have the very important role of the heart team. So, in my opinion, in my experience, how to solve a complicated problem, it means how to do the PCI in the elderly. The simple case we can solve with the simple way. The difficult case should be tried in the simple way if possible. But however, the complex complications could just be many successful with chip only. And so it is some summarization, some theory for the PCI in elderly patient. And by now I like to have the three guides for the demonstration. The first guide, left band PCI and CTO in the right coronary artery. So it means the left is last remaining vessel. It's very important. When we do the last remaining vessel, if something happens, the patient lost or hold the blood flow for the heart, and the patient fall into the cardiogenesis shock. Terrible. In the right, CTO and calcify. In the left, you can see diffuse lesion from the left man, but the mind, and particularly in the proximal and mid segment, and you can see the left give the collateral to the right. By now, the patient have a check band and non-STEMI. If we do to the left coronary artery, you can get obstruction, total obstruction of blood flow, and very easy to deal to give to lead to the complication. And in the left coronary, it have a small aneurysm. You can see small aneurysm. And our strategy, if we can open the CTO in the right coronary artery, it means we can get the native circulatory support, not mechanical circulatory support. We can break down large remaining vessel. So we try to do CTO PCI. I know in here we have some expert of the CTO PCI, look like Dr. Nguyễn Ngọc Quang, Dr. Ngô Minh Hùng. But try to do, and very lucky. Lastly, we can get successfully. After we get successfully and standing for the right, the problem become simple. Because as you see this picture, the right give back collateral to the left very abundantly, so we can do the PCI to the left. No worry about the compromised hemodynamics. So we do, and by now we in my cat lab we have the neurological intervention equipped. They can cause coiling the aneurysm very quickly. So I like to coiling before I do both dilatation, very high pressure in this area because it's very calcified. And the last result, the right. You can see the right after we open the CTO, it can give backward the very abundant collateral to the left. And we can do safety the left coronary artery, large remaining vessel. Okay, this is the first case. And the second case, I think that the second case it cannot solve the simple way because left main PCI with the calcified tortuous small diffuse disease. What you see in the right is tortuous a small diffuse and calcified lesion in the right, and the left we can see very calcified and tortuous. In the ordinary practice, in the daily practice, if the patient have the not severe, look like this guy, I don't touch to the right coronary artery disease because right coronary artery because it's very easy to make some dissection something, but because I like to do the PCI to the left, we try to open some parts in the right and obscure all the case the patient refuse or deny bypass surgery, or sometimes cardiac surgeon deny because in this look like this guy they say a very calcification and very difficult to insert the graft to coronary artery. And we try to open from the ostium to the segment to the midst of the RCI. It look like better, I don't know. Better or not better, I don't know, but I feel more confident to go to the lab. We go to the lab. Obscure in this case, we must do rotor-ablator because if we use only the cutting balloon or scoring balloon, it makes many dissection and overlap, very easy to get stuck to fail. We try to a rotor-ablator. After we do a rotor-bladder atherectomy with the support of the guided Z-LAD, we bring the digital stent to the mid of LAD first, and then the proximal segment with the second stent, and this is the last result. So in this case, we cannot solve the coronary artery disease in this patient with a simple methods. And one more case, you see very severe calcification of the distal ligament involved to the ostium of the LAD and circumflex. How we can solve with the simple method? I think no, we cannot. How we can solve with the cutting balloon? I think no. So we made decision to solve the problem with the rotor-bladder. First, we try to pre-dilatation with the small balloon, and we use the per 1.5 for the LAD first. After we do the atherectomy in the LAD, we deploy the distal stent first, and we go to the circumflex and we burr again. Atherectomy to the ostium of the circumflex. And by now we do the two stent technique. Okay, cross. And this is last result. And the last case for demonstration, left distal disease with quadrification. It means bifurcation, trifurcation, and quadrification. This patient were done the coronary angiogram for a long time, and she denied to circle bypass surgery. And so she suffered the check band for the long time. As you see, in the distal ligament, we have a trifurcation, a quadrification with the LAD circumflex and diagonal intermediate radii. And this is the last result. Up score, we should do triple kissing balloon. Last result. And the patient will follow up until now, 2022. This year, the patient will get coronary angiogram. It's okay. We use inverse it a little bit, the restenosis. So in my opinion, in my experience, how to solve the complicated problem, how to do PCI in the elderly, the simple case can be solved in a simple way. The difficult case should be tried in a simplest way if possible. And the complex or complicated, it could be managed successfully with chip only. I think so. And the take-home message: coronary artery disease in the elderly are often very severe, diffuse, tortuous, heavy calcified, particularly type C, bifurcation, ligament, triple vessel disease, CTO. PCI in the elderly require advanced technique and assistance instrument. We should have a good, appropriate plan or strategy before to do PCI in the elderly. We should do assessment of frailty, look like the presentation of Dr. Huang, and predict some difficulty, obstacle to overcome. In the case of very challenging left-man disease, many stage PCI may be reasonable, acceptable choice in older patients, particularly very high procedure risk. And we should have some requisite ability, IVI, plug modification, plug depoking, cutting balloon, rotor-bladder, and we should have a mechanical circulatory support Diep. We must do with a good team or teamwork. Thank you so much.
Yeah, thank you very much for the excellent presentation, actually. And the time is a little bit beyond the schedule, but I think we have to open for the discussion because it's very interesting presentation. So first of all, I would like to ask Dr. Rajesh about how to approach the patient like this, because Professor Hồ Tường Dũng gave us a lot of very real complex lesion. So how do you deal with the kind of lesion, for example, the CDO on the right side and the very significant lesion on the left side? So according to your opinion, what is your approach in your center? Dr. Kumar, yeah, Dr. Rajesh, please. Yeah. Yeah, Dr. Rajesh, yeah.
That was an excellent presentation, and you showed some of the most difficult cases and how you tackle those cases. Now, as far as the first case was concerned, where there was LAD disease with robust collaterals going to the right coronary artery, and the right coronary artery was a CTO, as well as the circumflex coronary artery was also a CTO. In US, probably we will do actually a hemodynamic support and address the left anterior descending artery, and simple reason being that is the artery supplies the majority of the myocardium. Because the lesion is quite tight, is calcified, and then after the LAD has been revascularized, and the CT of the right coronary artery and CT of the circumflex artery can be addressed at a later date. So that's how we will probably address that particular patient in our lab. However, what you described is also very acceptable, that CT of the right coronary artery can be addressed first. However, there could be some challenges at times opening the CT of the right coronary artery. And if those challenges are there, then you have to resort to coming on a retrograde, because there are robust collaterals from the left anterior descending artery that you can utilize to come retrogradely and revascularize the right coronary artery. So those will be my sort of way to address the coronary artery disease in this particular patient.
Yeah, thank you very much. And according to the previous presentation from Dr. Kumar, I think, so with the calcified lesion, I would like to ask Dr. Kumar that we talk a lot about the device, single device only, or we have to combine devices together in order to dealing with the calcified lesion, because nowadays we have to roll tablet or orbital before we put the IVL inside. So we have a lot of study coming in, like IVL with the orbital or IVL with the rota. So even the rota, in Vietnam, we use the rota and the high pressure balloon. So according to your experience, so should we use the combined therapy in order to dealing with the severe calcified lesion? Thank you.
So that's a great question. I think that has a lot of bearing on a lot of things. So I think the first and most important point is that we should not be doing combined modalities just because we can do combined modalities. Okay, it is not a matter of pride or glory or anything of that sort. It is a matter of what we can achieve and get an optimal result for the patient. I think that is the first and most overriding concept. Now, I recognize the fact that, especially in elderly patients, sometimes we would like to maybe avoid femoral access. And if you cannot get a big enough burr and it's a large vessel, you may have to use two modalities.
Yeah.
Typically, you may have to use rotational atherectomy followed by shockwave, or you may have to do orbital atherectomy. Orbital atherectomy combined with shockwave, it is possible, it has been reported, but I do not see any specific reason for that, because they both ablate both intimal and medial calcium. So I don't see the need for duplicating that. Whereas with rotational atherectomy and IVL, I see some potential synergy between the two, where one takes care of the superficial calcium, creates a pilot hole, and the shockwave then takes care of the deeper calcium. So I can see that, but I don't see a reason for some of the other combinations as to why they come about. However, different techniques may be necessary in different areas. Second important point is resource limitation. So, if you're functioning in a scenario where resources are limited, or certain technologies may not be available, like for example, IVL, you were telling me earlier that IVL itself was not available.
Yeah.
Then you have to work with whatever techniques that you have. And typically that would mean that if you have rotational atherectomy, you may subsequently need to do, you may subsequently have to use a cutting balloon if IVL is not available. And rotacut is actually a very good strategy for complex PCI for severely calcified lesions. And so that may be a very, very cost-effective strategy with the cutting balloon following rotational atherectomy as well, that can solve some of these issues. So I think, you have the combination strategies, you can combine them in a suitable manner to get what you need. Now, if you have invested and purchased the intravascular ultrasound catheter, there is nothing to stop you from, after you do the rotational atherectomy and the balloon inflation, to quickly put the IVUS there and see, what has happened. If you have achieved the calcium fracture, then you can expand it and deploy the stent successfully. But if you have not achieved calcium fracture, then you have to go further. And whether it's a cutting balloon at that point, or whether it's going to be IVL at that point, that depends on what is available and what the resources are. Thank you.
Yes, thank you very much for the excellent answer for Vietnamese doctor. And I think that we have limited of time, so I just have the last question for Professor Phạm Văn Hùng, that in PCT this year they talk a lot about the more is more and the less is more. More is more that we use a lot of device in order to get a good outcome for the patient. So for this, the elderly, and with the presentation of the Professor Hồ Thiên Dũng, so Professor Phạm Văn Hùng, what do you think about that? We have to use the imaging device or even the physiology in order to evaluation the lesion, and a lot of device in order to get a better outcome for the octogenarian patient when we do the PCI for them. Thank you.
Thank you so much, Dr. Hồ Minh Hùng. I prefer the less is more. Is my also philosophy of the practice. When I was young, I want to use a lot of the modality for intervention and want to do a lot of complex case. But nowadays I get more and more older, so I just thinking that less is more. But in my opinion, it's quite depend on the lesion. When we use coronary angiography first, we saw the patient and we can evaluate, and also based on the patient situation when we decide. So I think that it's most of cases we just only using the choangiography to decide for intervention, but it's some very complex case when we need to use some further modality like FFR or the IVERT, we may use, but I think I prefer the less is more. Thank you.
Yes, thank you very much, Professor Phạm Văn Hùng, that we have to escalate with the situation required to have to escalate in order to get a better and good outcome for the patient. And I would like to thank you, Professor Hồ Thiên Dũng, for the excellent presentation and the discussion from the panelists. Because the short of the time, and I think that I would like to invite